In this talk, we'll see about the anatomy of the Cox triangle, its relevance to AVNRT ablation, and anatomy of the outflow tract. So this is the anatomical picture where the RA has been RA and the RV has been cut away. The catheter is passed from the IVC into the tricuspid valve. This is IVC, this is the CS, okay, and this is the CS roof of the CS. This is a eustachian valve which is protects the IVC. Then from this is follows is a tendon of Todaro. This is a septal leaflet of the tricuspid valve. This illuminated structure is the membranous septum. The septal leaflet of the tricuspid valve divides the membranous septum into the atrioventricular portion and to the interventricular portion. The atrioventricular portion, if you poke from here, it goes into the, you can go into directly into the left ventricle. This is the interventricular portion. So this is a Cox triangle. This is formed by the roof of the CS os, septal leaflet tricuspid valve, and a tendon of Todaro. The apex of the Cox triangle is the bundle of his. This is a blown up image of the same. This is a Cox triangle, and this is septal leaflet. This is a membranous septum. So in this image, you can see this is the AV node. AV node will be lying here, and it is superficial. As it goes more deeper, it forms a penetrating bundle of his and divides into the left bundle, which is comes onto the LV side and more in the endocardial LV side, and this is the right bundle. So you can see that the AV node is a more superficial structure, while the his bundle is more deeper and it is insulated structure. So when you ablate in this region, this is a usual slow pathway ablation region, right inferior extension of the slow pathway is the region. As we go higher up, we can damage the AV node. When very rare, if you go here, you can use the bundle of his. But as the bundle of his is deeper structure and is encapsulated, the risk of injury to bundle of his is less when compared to AV node. But still, it should not be. It should not go more than the higher than the CS roof. So this is a picture. It is a LA view and this is RA view. This is this pink is the right inferior extension of the AV node region. This is the most commonly involved in 85% of the typical AVNRT. So ablation of this region takes care of nearly 85% of this. Ablation in this region does not terminate the tachycardia. Tachycardia is repeatedly inducible. Then you have to go into the CS and look for the left inferior extension. So this is a right inferior extension is on the between the tricuspid valve and in the CS os and slightly into the CS also. So when we put the catheter from the IVC, you have to go into the tricuspid into the RV and slowly pull back. And when you have a fractionated A with a large V, the A signal should be usually less than 1/3 of the V signal. At that area, you will get the, you have to ablate, you will get the junctionals. So in this picture, sorry, I think pointer is not working. In this picture, the interventricular septum has been cut away. This picture I shown because you can see it in the CS os, the anterior wall of the CS is close in close relation with the AV nodal artery. So sometimes involuntarily ablation of the during ablation of slow pathway, the AV nodal artery may get injured, so it can cause a transient complete heart block. This is a picture of the in the RA view. Here we can see that in the AV node is more inferior, while in the B, the AV node is more superior. You can see that the AV node is differs from anatomy, differs from people to people. Some people will be more inferior, some people will be more superior. So if you, in case of slow pathway ablation, if you go more superiorly, more than the superior to the CS os roof, there is a chance of injury to the AV node. So always keep the ablation below the CS os roof. This is a picture. This was arbitrarily the region has been divided into the P, M, and A, posterior, mid, and anterior region by the Masurakta group in Milwaukee. So what they found in the ablation in the P1, P2 region, that is the posterior region, has had no AV blocks, while the ablation in the higher has found to have increased AV block. So, sorry. So you can see in that left-hand figure, this blue is the typical right inferior extension of the slow path will be present, while the red behind the tendon of the red is the fast pathway of the AV anatomy circuit. So ablation below is safe. As you go higher and up higher, the chance of AV block is higher because of injury to the AV node, or very rarely when you go more posterior behind the tendon of the Todaro, there's injury to the fast pathways, which also increases the risk of AV block. This diagram, this picture I have put to look to show the close relationship of the membranous septum and the non-coronary cusps. So in the first diagram is the L view where the RV has been cut away. The eliminated region is the membranous septum and the catheter has been placed there. As we already said, this is the apex of the Cox triangle where the bundle of His is present. So you can see that it is in close contact with the aorta in the first picture. In the second picture, you can see that the catheter has in the same region. It is, we have been LAO which slightly, we are seeing from the foot end of the patient where the tricuspid valve and the mitral valve has been cut away. And this catheter is in close contact with the non-coronary cusps. Non-coronary cusps of the aorta. The same thing in the last image is a RIO image. RIO image, I'll show it in another picture where it is in contact with the aorta and which is non-coronary cusps. So in cases of atrial tachycardia where the earliest A is in the His bundle region, ablating in this region in the right side can increase the risk of AV block. Hence better always map in the non-coronary cusp and you can safely ablate most of this tachycardia from the non-coronary cusp region. Coming to the next topic, outflow tract anatomy. We all know that RV is to the right of the LV, but another most important thing is RVOT crosses the LVOT anterior so that the pulmonary artery comes to the left of the aorta. So this picture, you can see that the RVOT crosses in front of the LVOT and the pulmonary valve is superior to the aortic valve. It is to the left and left of the aortic valve. And pulmonary valve is horizontal, while the aortic valve is inclined about 30 degrees to the horizontal. In this picture, we can see that the posterior infundibulum region of the RVOT is in close contact with the aortic cusp, mainly the right coronary cusp. So this is anatomical picture. The above one is the free wall of the RVOT. Then in the down picture, we can see they were marked as 1, 2, 3, and 4 and 5 sites. One is the RVOT free wall, and 2 is the posterior infundibulum of the RVOT, which is in direct contact with the 3, which is the right coronary cusp. And then 4 is the aortomitral connectivity, and 5th is the mitral valve annulus region. So as VPC origin moves more from anterior to posterior, you get a small R in V1 in case of a sites at 2 and 3, and as you go more posterior, it becomes more R gets more prominent. Finally, you get a right bundle branch block by pattern like in the mitral annulus. So we can see that the 2 and 3, if the mapping in the posterior infundibulum, if you're not ablation in that region is not successful, then you have to go into the right coronary cusp and map in the region, because VPC morphology in ECG will be nearly the same for posterior RVOT infundibular region and also for the RCC. So this diagram, we can see that the catheter has been in the membranous septum in the bundle of His region. That the lower one, the posteriormost cusp which I have drawn imaginarily with the black line is the non-coronary cusp. And this mapping in the posterior infundibulum is in close contact with the right coronary cusp. As you go leftward in the RVOT, go map more leftward in the RVOT, we'll think it is in contact with the LCC, but it is separated from the LCC by the adipose tissues, fibrous and adipose tissues. That will show in the next diagram. So this is a same image. We have the level where RV has been cut away and catheter is placed in the membranous septum. So we can see that the RVOT posterior septum is in close contact with the RCC, but when we get more leftward, you can see that this RVOT posterior septum, posterior inferior RVOT, which is in close contact with the RCC. This is the NCC. But when you go more leftward, we think it's in contact with the LCC, but it is separated from it by adipose tissue, and we can see that there is a left main coronary artery in this, just posterior to the most leftward region of the RVOT. So ablation in this region should be very careful because we can injure the left main coronary artery. You can see that this is the LAD and this is the LCX. This is the LV summit region. So LV summit region can be approached either from the RVOT more leftward portion, or from the left coronary curves, or from the aortomitral continuity, or from the great cardiac veins, or from the true epicardium. So this is the same where this is the NCC, this is a RCC, and this is LCC. This is a tricuspid valve been cut away, and this is the mitral valve. You can see that the RV posterior inferior region is more in close contact with the RCC, while more leftward as they go, they are separated from the LCC, and this is the LAD. This is LCC. So for mapping for in this region of the LV summit, it can either from the LCC or from the more leftward or RVOT or from the great cardiac veins. This is the same picture that was seen from below. This is taken from, we are seeing the heart from above. So this is a mitral valve, this is the tricuspid valve, this is the non-coronary curves, this is the left coronary curves, this is the right coronary curves. You can see that the non-coronary curves, this will be the bundle of His region. So non-coronary curves is in close contact with the mitral valve and the tricuspid valve and the interventricular septum. So if you want to map for any atrial tachycardia, you can map from the non-coronary curves. As you can see, it is not in contact with the ventricle, so usually you will not get any ventricular signals in the non-coronary cusp. This is a left coronary cusp. So this is the leftward portion of the RVOT, and they are separated by this left main coronary artery, which divides into the L6 and the LAD. This is the RCC, which with the arteries. So if there is any posterior septal, posterior inferior bundle of the RVOT signals can also be mapped in the RCC. This is the same thing as this V1 will be here. So as you go from anterior to posterior, there will be a prominent R in V1 will be present. That's all. Final take home is in. At the end of this topic, we should know about the Cox triangle anatomy, which is formed by the septal leaf left of the tricuspid valve, CS os roof, and by posterior by the tendon of Todaro. Slope pathway ablation is predominantly from the right inferior extension. It means anatomically it should be below the CS os roof. As we go higher and higher up, the risk of AV block increases. And for mapping for any tachycardia in the bundle of his atrial tachycardias, you should map in the non-coronary cusp. Coming to the outflow tract anomalous, RVOT and LVOT cross each other so that the PA lies to the left of the aorta. And origin of VPs is, as we move from more anterior to posterior, R in V1 becomes more and more prominent. Thank you.